So we're just going to kind of go through a few questions, and at the very end, if you guys have questions that you're thinking about, be writing them down. We'll have maybe 15 or 20 minutes at the end to talk through some of your guys' questions. So just first off, I'd like to just go through, and they're going to introduce themselves, kind of what capacity they work in, and some of their perspectives. So we'll start with that.
So my name is Steve Hargarten. I'm trained as an emergency physician. My experiences range from fourth-year medical student being in Nicaragua to doing my internship in the Canal Zone in Panama to volunteering at a refugee camp in Thailand. And I thought, boy, gee, I think I should study public health. So I did my master's in public health in 1984, practicing emergency medicine all along the way. Joining the Medical College of Wisconsin, we got immediately involved in training emergency responders in Poland. As they were transformed into a newly independent state, they needed a strengthening of their emergency services. And we've been doing that kind of training ever since, and fast forward now, we are in an active project in Belize, strengthening emergency care at Karl Kushner Memorial Hospital in Belize. I'll stop there.
Good morning, I'm Jono Anzalone with the American Red Cross. Also serve with the International Federation, done some work with the ICRC in areas of post-armed conflict. I'm the probably only non-medical person on the panel. I'm actually an economist. But as you probably are all familiar, the Red Cross has a role both domestically in relieving human suffering, which has touch points with the health services community, but internationally, our gamut of services from emergency management stem from surgical management in war-torn countries to public health outreach. So wide experience. I'm fortunate to serve in about 23 delegations with the International Red Cross. Still go out about once a year in addition to my domestic duties, and just fortunate to be here. Creighton's my alma mater, so I'm glad to be home.
Hi, I'm Stacey Chamberlain. I'm an emergency physician from University of Illinois at Chicago, and my work has primarily been with a nonprofit organization that I co-founded called Global Emergency Care Collaborative, and we've been focused on developing emergency care pretty much in Uganda through mid-level provider training to using a task shifting model to help train providers to learn how to do acute and emergency care services. And we also partner with local universities there that are trying to start the physician training piece. There's not yet an emergency medicine residency program in Uganda. There are several in sub-Saharan Africa that have started in recent years, and we're working with Embarara University of Science and Technology and with Makerere University, who are trying to start the physician level training as well.
Thank you, and I just want to say I'm so impressed with this conference and the student responsibility for it. It's wonderful, and I congratulate those that are involved in it, and glad to be here. I'm a faculty member in the surgery department here at Creighton University, and our son, who went to Creighton, went to the Dominican Republic and the ILAC Center and said, "Dad, you got to go." And I said, "Well, they don't have any surgical facilities." They did develop a beautiful operating suite there. And so we started doing hernia operations. We started a nonprofit organization, Hernia Repair for the Underserved. We've done a lot of surgery in Western Hemisphere countries, 10 different countries. And then also started a diabetes hypertension program in the Dominican Republic. I don't have any global surgical experience with emergency medicine and or trauma, but I do in terms of elective surgery. I guess we keep this.
Yeah, I can just. So there's been a lot of talk recently about, I think Paul Farmer, he wrote an article 2 years ago, and he called it the neglected stepchild of global health, and he's referring to surgery and emergency care, and yet I guess here in the States, emergency medicine and surgery looks so different than in the global setting. So if you guys would just comment on how you see emergency medicine and surgery. What does it actually look like? Are the differences you see or have experienced, and just things that have kind of shocked you about how different they are, what it looks like?
So in terms of emergency care in resource-limited settings, it is very different than here and in a lot of my training. So we are really focused on using existing resources, and sometimes we even shy away from the term emergency care because too many people around the world have seen the show ER, and they just have a very biased perspective of what emergency care means, and that's really not what I'm talking about. So it's, people have all kinds of acute care needs, and a lot of times in resource-limited settings, their last resort is to come to the clinic or the hospital, and oftentimes they're quite sick at that point. So when we're focused on training providers in acute and emergency care, we're training them to use the existing resources they have. So we've been working at a district level hospital, so they do have the capacity to start IVs there. They have IV fluids, they have antibiotics. They're able to do basic testing like, blood testing, malaria tests. They can do a lumbar puncture and look at the CSF, and trauma care. So there's definitely a huge burden of injuries, and we're only seeing that rise as the years go on. So we're really, we're not teaching people to use these advanced modalities. There's no telemetry monitoring. We don't intubate people because there's no ventilators, and even if you had a ventilator, there's no reliable electricity, and there's no intensivists who know how to run them. And so it's not like what you see on TV. It's just recognizing really sick people and treating their infections aggressively and hydrating them and treating their wounds appropriately to prevent just a lot of really unnecessary death from easily treatable conditions like diarrhea and malaria and pneumonia and injuries.
Yes, and building on those great comments, what we're seeing, as well as the framing of this of delivering great emergency care, that the disparity of resources is starting to close. And what we're seeing really is the cultural issues surrounding the team approach of delivering care. And when I've gone to some locations, I felt like I was going back into the 1960s with the United States, where the nurse gets up for the physician. I wish those days, no, just kidding. So it's so interesting about the hierarchical cultural issues. The nurse is standing and waiting for the physician. And the team-based leadership development is what we're focusing on in many places to complement delivering good care, not requiring high-definition CT scans. So I think that's a very important area that we're seeing, and seeing the organization of emergency services. I was at a hospital in China, in a suburb of Shanghai, and I felt that was back in the 60s. You have a headache, you see a neurologist. It's an old model that's inefficient, inappropriately subspecialty oriented. So there's a lot of work to be done in organizing these services. The content expertise of these providers is changing, and it's important and it's good. But the structural issues, cultural issues, the leadership issues are what we're seeing are the real long-term investments that we're going to need to see, because in organizing the services better, then we're optimizing and positioning the patient to be best served by a trauma center surgeon and the whole system of care too. So I think that's a real fascinating part that we're seeing as well.
From the nonprofit perspective, I think certainly we heard in this morning's keynote speaker the importance of meeting the community where they're at and engaging community-based assets. There's economic modeling around asset-based community development, and much of our International Red Cross, Red Crescent Society approach is about making sure that we don't have a bunch of expats coming in providing emergency services and surgeries, but trying to find a sustainable way to build a community I use the Mexican Red Cross as an example, one of the largest ambulance providers and emergency service providers in the country, because of limited infrastructure in certain parts of the jurisdictions that span across Mexico. And each Red Cross society, like the Belize Red Cross or the Mexican Red Cross or the Suriname Red Cross, finds itself trying to find ways to make for a more sustainable medical environment instead of what USAID encourages at times, which is small 2-3 year based, community-based projects, which have no sustainability absent the funding. So trying to find ways that we're not just going into communities as a Red Cross provider and making sure that you mirror money, man and woman power and material in a way that outlives any particular service learning trip or community-based intervention.
Well, hernias are not an emergent situation, but I can tell you and I'll just give you a life experience with the inadequacies. In the Dominican Republic, we had a patient that we were going to put a shunt in for dialysis. And after the shunt was placed, his potassium was measured, and it was 7.4, and he had a fantastic arrhythmia. And so we called the ambulance in Santiago, Dominican Republic. This is a city of 1 million people. And after about half an hour, and they said they'll be there. And we didn't hear a siren, and then another 45 minutes, and still nothing. So we put the guy on a mattress in the back of a pickup truck and drove crazily through the streets. It was quite a ride, and got to the emergency room, which was absolutely packed with people. There was plaster on the floors in the ortho room, they called it that. And the only place they could put us was up on a floor. There was no oxygen, and for 30 minutes we tried to get him oxygen. Finally, I had a little tirade, and we got some oxygen, and eventually he did get dialyzed. But the inadequacies of these circumstances are far beyond your imagination if you've had any experience in a modern hospital. So there are tremendous needs, and I can personally testify to that. In terms of, and I like what I've heard from the panel members, and that is that it's got to be a mature, not self-gratifying approach to caring for or helping in these countries. It has to be about helping them build their systems and their capacity. And that focus, I can tell you that with hernia surgery, there were teams going to sub-Saharan Africa and having very high mortality rates. The mortality rate for hernia operations should be 0.001 almost. And they were having 20% mortality rates because they were doing just tremendously substandard surgery. So one of the things that we try to do, and it is appropriate to do elective surgery if the patient absolutely cannot get access. And this is always going to be a very remote area. So now they're building trucks with operating rooms to go to remote areas. But if you're going to do surgery for people that the country is not providing, it needs to be high quality. And that is being more understood now by teams going, but a team going for a week is rarely going to make a difference in terms of the country's system problems.
I think that's a good, segue. It's so easy to look at the one moment of the things that are on the ground. So doing a hernia or placing that IV, but to actually get there, it takes so much systematic policy and implementation from the top down. Have you guys seen how the programs and policies then I'm sure in the middle of it from top down, how have you seen programs and policies work, or just your experience getting that IV? It took so much from top down just to get that IV placed. What have you guys seen in programs and policies in your, interaction with that?
So we're fortunate to have a large presence. Our headquarters is in Geneva, Switzerland, and a large part of our mandate under the Geneva Conventions is to really work on diplomacy issues and policy issues that would impact systems in countries where we know that there is human suffering. So a good portion of our International Federation and ICRC component, the medical team focuses on those macro issues that will help enable in countries that have substandard care, whether it's lack of trained medical professionals or access to the materials to make it dignified and humane. But on a very localized basis, especially in kind of what I consider the most war-torn of the war-torn, we spend an inordinate amount of time working with ministries of health and other cabinet-level ministries to help gain access, and in particular in a way that is subject to our fundamental principles of being impartial and neutral. In areas of armed conflict, that can be very controversial because we have a mandate under the Geneva Conventions not to take sides in parts of conflict, and especially when it comes to care of wounded combatants that are no longer armed. So we do detention visits where we find ourselves with our surgical team having to administer medical care under the worst of conditions because these are individuals that have typically been locked up and are derived of their freedoms. And from a humanitarian perspective, we try to embrace those departments of interior ministry to make sure that those individuals are also afforded the same level of care. It's not always a scenario that we win, but it's certainly one that we believe we have a mandate under the Geneva Conventions and from a humanitarian perspective.
So it's interesting to follow up with that. Emergency medicine was the first specialty that came about directly as a result of meeting the needs of patients. First specialty and only specialty that's totally devoted to the care of patients 24/7. That's how we began. So we don't have those other specialty boundaries. So it really is a mantra of emergency medicine. We start out, no questions asked, what are you here for? How can we help you? And that's really how we built our specialty in and replicating what's happened politically in this country is literally and interestingly being replicated across the globe. So what happened in the 60s? We have a problem with emergency services and the care of the injured patient. National Academy of Sciences publication, 1966. The political will changed, and there was monies for paramedic training, for emergency services, and for trauma centers. 1970s, paramedic programs. First emergency residency, 1971. You see that march of doing what's right for patients 24/7 in the out-of-hospital setting. You're injured, you're sick, a system is developed. They are systematically cared for by then now emergency medicine physicians, not a neurologist if you've got a headache or a dermatologist if you've got a rash. And now we're looking at that systemization occurring across the globe. And the political interests actually pay attention. Ambulances are visible. And the policymakers go, we're doing really well. We're devoting monies and resources to ambulances and so forth. So I think there's some real policy issues that I'm very proud to see that emergency medicine is in the forefront of those systems developments in partnership with great agencies like the Red Cross. And now WHO has declared emergency service is a right for everyone to have. Emergency services are a right. So it's a changing landscape that now we are being asked, we want to develop services in Tanzania, services in China, services in Belize. And by taking the patients in an organized way to a hospital, to the point made previously, the hospital is disorganized. Let's organize the hospital. So you march them through, organized from the curbside to the bedside of the emergency department, to the operating room, to the intensive care unit. And that flow is actually well recognized by the policymakers and go, we need to do a better job because it's all about our patients, all about our community. It's a really very important moment with the Lancet Commission now talking about global surgery. A system of care now really begs itself to be fostered, nurtured, supported, and getting trained people for the right patient, right place, at the right time.
I'd like to echo what Dr. Hargarten said. one of the biggest things in the recent years has been sort of more global recognition of the need for these types of services, and the World Health Assembly passed a resolution basically acknowledging that this is an important part of a public health care package, that these are public health issues. I think some people think of surgical and emergency care services as being just something that's that's for much later, once we have more developed healthcare systems, and we just need to focus on primary care, and of course primary care is absolutely essential, and it's definitely a priority, but there's no reason that we can't develop these other services in conjunction, and that it really is a public health issue, because these are population issues where you have people with acute care needs and injuries who are not being treated. And so I think the recognition by the World Health Organization has been huge. One important thing that I've seen in terms of policy, and where my organization has been focused, is on using task shifting. This is something else that the World Health Organization has recognized and promoted. So task shifting is sort of self-explanatory, but it's shifting tasks from one level of provider to a different cadre of provider, and usually that's people who've had less extensive training and education. And so this has been huge in surgical services, and particularly in obstetrics, where a lot of times mid-level providers have been treated just to do cesarean sections, and that is their focus. That's the only surgery that they do. And so you have many countries like in Mozambique and Malawi where all these C-sections are done by mid-level providers and not by physicians. And I think that's a big area of policy, and that's where my organization is focused in Uganda. Is it's important to train physicians, but we take a long time to train, and we're very expensive to employ, and retention is poor. So it's hard to, even in the States, it's hard to keep physicians in the rural areas. And that's certainly the issue in a lot of these countries, and you have issues of brain drain and whatnot. So if you can treat nurses to do a lot of these services, and they have higher retention rates, and they're faster to train, and they can still provide the same quality level of care, that's an important sort of policy strategy to address some of these human resource gaps.
I would agree with that, but I think it depends upon the disease process. I would agree because we have a diabetes hypertension program that I mentioned in the Dominican Republic, and we have cooperadores. These are healthcare providers, lay people elected by their small village, totally volunteers, educated on basic health issues, and they work with our patients. They know the patients. They live with the patients. And we do A1Cs, and we do blood pressure normalization. We have a dashboard, so we keep careful data. And actually, with these cooperadores and in-country physicians, we have better A1C and blood pressure normalization rates that a comparable group would have here in the United States, because the cooperadores know the people and live with the people, so they remind them to take their medicine. They take them physically themselves to the appointment. It's amazing, and it's wonderful. They're very invested. They're proud to do what they are doing. And the ILAC Center, for those of you that might have the opportunity to go there, has probably the most mature healthcare promoter system maybe in the world. It's 35 years old. And so they've been doing it for a long time, and they know how to do it. It's worthy of investigation. I don't think we've maybe made it public enough for people to understand the way they do their healthcare promoter method. They have 165 healthcare promoters in this one center. However, with hernia surgery in developing countries, there has been some research done on having nurses do hernia surgery, and it has not been satisfactory. This is nurses in a developed country, a high-income country. Hernia surgery is common. It is relatively simple in relationship to a transplant or a colon resection, but it has a lot of subtleties, and so it isn't something that you can transfer easily. A C-section usually is about the same. The anatomy is not terribly different, but the anatomy with hernias, inguinal hernias especially, it can be very challenging, especially in developing countries where they're very large sometimes. So I agree with what you said, and just saying that the disease process dictates that a little bit. What we have done to try to build capacity is work with the Ministry of Health in Haiti and developed an education program for in-country surgeons through the Ministry of Health and the Haitian Surgical Association. Signed a memorandum of understanding, and now we're going to develop a center of excellence for hernia repair in that country. But one of the things that we haven't talked about a lot here, that I know that the panelists would agree with me, is, I hope they would, is that access is a huge issue for elective surgery and certainly for emergency care. That is, the person getting to where they can be treated. And with elective surgery, it's being able to afford to get there. So that might be something we can talk about a little bit.
Yeah, and Dr. Chamberlain, it's interesting you kind of saying, starting from a policy level and now seeing, mid-levels doing C-sections. This last summer was in Kenya, and I was on call one night and called in for a C-section. And the person who was teaching me how to do this kind of asked them about their training or whatever, and they were kind of near a third or fourth year medical student level, and they'd already done 200 to 400 C-sections already, and I was just shocked. But it's cool to see that from a policy standpoint or program standpoint, how that's taking place. So it was awesome to see.
Well, there's been a lot of task shifting, as you said, like with health promoters, so not just at the emergency and surgical level of things, but just with primary care. And I mean, that's how they were able to roll out a lot of the HIV programs in sub-Saharan Africa, is to have community health workers and health promoters ensure that people are taking their medicine and things like that. So it's, I'm talking about task shifting from, physicians to nurses, but there's, nurses to technicians or technicians to community health workers. And I mean, it can happen at many different levels. But there does have to be quality assurance involved. And not everything can be shifted. I mean, it's very essential that if you're going to shift tasks, that it has to be done where you can make sure that the quality is maintained.
Just two quick additions. It just struck me that that's actually how emergency medicine started, was task shifting to the bedside 24/7. Instead of calling an anesthesiologist to intubate, we do. Instead of calling somebody else to manage a headache, we do it. So that was interesting. I didn't think about it that much, but that's really how it started. And now we're really seeing the benefits of task shifting across nurse practitioners and other professionals to do these things. It's really interesting. And two, this all really requires solid quality leadership, so that the system of care is accountable, high quality, and then you've got specialized areas of excellence of hernia repair, having people who are available for C-sections, but there's some leadership requirements that I think are really, really important to make sure we keep. I didn't realize I was a task shifter.
So,
Can I just say one thing?
sure.
We have identified a leader in Haiti who has helped us. In fact, it was his idea to establish a memorandum of understanding for training of his surgeons that he had trained, actually pretty much countrywide trained. But networking is the way we wound up meeting this man, and these conferences are wonderful. So your opportunities are going to come from networking a lot of times. You meet somebody casually, and all of a sudden they have been doing something that's important. And I didn't meet this surgeon in Haiti. It was about 3 different people before I met him that had worked with each other. So it's important to talk and find out from each other.
So this time we're going to just open it up to questions for you guys. I'm sure there's lots of things we talked about, anything that kind of hit you in particular, if you have specific questions for these guys or just in general, we'll just kind of go around and pass around a mic.
I'd like to start, thanks. I'm Jan Springer, and I've done relief work. I started relief work with a team that's been in Honduras since the 80s. And what has struck me about these models is in that group that is still going down there, I think they leave next week, I don't see ever any light at the end of the tunnel. I don't see that country is going to be able to ever sustain their own healthcare delivery system. And there's a little conflict, I think, in the people coming from outside to make it better. You know, there's a way of saying, yes, we're going to help build this, but are we going to help build it and then let you have it? Or you're going to be able to take it? And what's your vision in the work you do? Do you see that actually? Are we building those blocks? Or I don't know. I'm just interested in your philosophical perspective.
Well, I do think we could disable the country by giving them too much, or overload their system by doing 100 hernias in a week, and they just cannot follow the patients adequately. But I do think, and I understand, I mean, maybe there is no way to assist and or enlighten the Ministry of Health. They just are uninterested. And that has been our experience in the Dominican Republic for diabetes and hypertension, and for hernia surgery too. They are uninterested. And we want them to have A1C machines. They do not care. They don't. But you can educate the people at the lower levels and help them. And we feel that that's the way we can work in Haiti, where the Ministry of Health is interested, interestingly, and also in the Dominican Republic, we can educate the surgeons to do the operation correctly, and the nurses and the anesthesiologists to give the anesthesia correctly, which some of them don't know how to do. What we found with the surgeons in Haiti is that they're operating at about a third-year surgical resident level, so there's a lot to teach them, and they're open to it.
I think in my experience, it's challenging to have that long-term vision, but it's essential, and that's where a lot of the hard work comes, and it just comes with year after year of building these relationships and trying to collaborate. And where we started our training program, we were sort of working in a little silo at one hospital, and the people that we trained, they have this higher level of skill, and their patients are having better outcomes, but initially when we started, we weren't integrated into the local educational system. So they finish our course, and you get this certificate that says, okay, now you're an emergency care practitioner. Well, it's not recognized nationally, and it's not a portable degree, and they can't go to any other hospital and get paid commensurate for their level of expertise. So we've been working now for many years to get our program integrated with a local university, so that it's a diploma-bearing course, and so that the Ministry of Health recognizes this new level of provider. And it's painful, and we thought we'd have this done 5 years ago, and we're still not there, but we just keep going back and trying to make it more sustainable so that our new graduates will, and eventually hand it over completely, so that my organization will not be running this program. It's a local university who has taken over the program. So we're working towards that, but it's very challenging.
Just a real quick comment. I think Janice will know this because we work together, but so much of what the Red Crescent mission is about is remembering that the humanitarian imperative has to come first. And there are many difficult decisions when we do medical care in countries where we know there's not sustainability, that it is simply about saving lives. And each organization, I think, has to find true to their mission and to their values and their ethos, what it is that they're trying to accomplish. Because in the end, there are countries that we serve in, 79 delegations that we have permanent missions in, that we know there will not likely be a sustainable system in place. But our core mission is remembering that somebody still has to go and save lives and protect lives. And that's difficult because some organizations don't have the funding to do that. So I think that it certainly poses a moral ethical dilemma in terms of the own missions and values of your organization.
So this is a big deal issue. And I'm sorry, I think people, when they talk about I'm going on a mission, well, I'm thinking Mission Impossible. Maybe that's what Honduras is for the moment, because it's got one of the highest gun fatality rates in the world. We've got to get this right. And to Dr. Chamberlain's comments, it's a long-term investment, and we need to be serious about this. Imagine a group of Nicaraguan physicians coming into northern part of Omaha and saying, well, we're going to distribute medications for a week. Really?
Yeah, I have one.
So I think brigades and missions, I know that I'm sorry, I don't want to mean to offend anybody. That's an old model. We need to have long-term sustainable solutions, and it takes work. It takes work to meet with the mission. I met with the PAHO mission. Boy, it was kind of disappointing. We need leadership in those places, and we need to push for that. It's a real issue that goes to the core of global health. International health, old model. We go to Malawi, study malaria, boy, that's really cool. And somebody says, well, I'm a humanitarian. And I go to Haiti and I do my humanitarian work. So when you come back to Omaha, you're not a humanitarian? Well, what's that? So we have had series of conversations about this, and you can see it. It's viscerally important for us to get this right. Because your point's well taken. What are we doing? And I think the investments that you're seeing, as Dr. Chamberlain's outlined in kind of, we need to eventually leave because our job is done. That's the way it should be because it's in the fabric of the country that you're there. In Belize, they think we're some sort of volunteer organization. Oh, he's back. We've been there for only 4 years. And they think we're some sort of volunteer do-gooders. No, this is a serious business of strengthening emergency services for tourism, for their economy. And still we're viewed as some sort of mission do-gooders as opposed to, this is what we do. And we strengthen the country, hopefully, and we meet with people and try to do that, but it takes years because there's politics and all this other stuff, and it's a partnership with the leaders at, in this case, Belize City. So you've touched on a very important issue of global health, and it's not over yet.
Go ahead.
Yeah. This past year, I led the first, or I was one of the teachers for the first paramedic education program in the Dominican Republic, and I can definitely attest to your experience. It's very accurate. And one of the ways we actually found success is getting absorbed by, having the course absorbed by the university. But I also taught an out-of-hospital care program in Nigeria this summer at the teaching hospital, which is also a very different thing because in the Dominican, we were supported by a missionary organization. That's how we were able to gain most of our supplies. So I was really curious as to what John's perspective was on how to create financial sustainability without leaning on a missionary organization, and also Dr. Hargarten's perspective on how you approached starting EMS in Poland. How that went. Did you just get a grant from the government? Did you start at one hospital and work for the rest of the country? How did you approach that?
So real quick on my perspective, we do a lot of asset mapping before we enter into a mission or a program within the country, not only to best analyze from a SWOT perspective where their strengths and weaknesses, opportunities and threats, but really to try to analyze who's already doing that. To the point that you made earlier about kind of medical missions and what I refer to as medical tourism that go in despite the fact that there might be market saturation in that particular thing. I was detailed at USAID during the Haiti earthquake, and the number of physicians that wanted to go without supplies, without a contingency plan, without a destination, broke my heart, right? All do-gooders, but what's the point, right? They created a huge liability for the U.S. government on the ground, sleeping in front of the U.S. Embassy. So doing asset mapping prior to entering into those conversations that from a very finance and economic perspective is tied to who's funding those programs. Because the big pots of money that are out there have very strategic goals and objectives that may not align with what it is that you're trying to accomplish. And I know that seems very simplistic, but wanting to do good is not going to get you there. And it will not sustain you. Finding sustainable financing solutions through WHO, IMF, African Bank, ECHO, there's a number of these huge pots that before we enter in, we're very strategic in asking those questions. And then obviously partnering with organizations that may already be doing it but need additional expertise, extra money, manpower, material. But it's amazing to me. I mean, the blending of global medicine with some solid business practices, I think, is necessary because you can have soul and you can have passion, but that will get you only so far.
There were two disasters in Haiti, the earthquake and the deluge of non-governmental organizations, one of which introduced cholera. So it's horrible. Regarding the Polish project, so back in 1989, 1990, those Eastern European countries became independent from USSR. So Poland became one of those independent states. The first President Bush had a USAID program of strengthening healthcare services in those countries. We applied for emergency service strengthening because that's one of our strengths. Milwaukee has a significant Polish population, so the relationship building was natural. One of our congressional leaders is Polish American, so we naturally had an affinity for Poland. We didn't go to Hungary because we didn't have that heritage. So to the points made, it made a logic for us to go to our strength, emergency services, to the relationships and culture which we have in Milwaukee that helped frame the proposal. We were fortunate enough to get the monies, and we began to build relationships to strengthen emergency services in 3 cities, Białystok, Łódź, and Krakow. And there was a concerted effort to partner with universities, the academic quality, and to target physician leaders, again, building on what we did and have done in Milwaukee. So it was a natural flow. We didn't create things that we didn't have, build on our strengths, which I think goes to your question, is what makes sense for you to do some work in an area is when there is that relationship and opportunity. The USAID grant had significant resources. Unfortunately, they don't do that as much as before. So it brings us to a fast forward. In police, we were invited. The intensivist said, we want to strengthen emergency services at Carl Eustner. A conversation took place. We were asked, we were invited. Key issue. We're invited to do this and partnering, and as a condition of doing it, we wanted the Ministry of Health to recognize that this is a long-term partnership from the beginning. So setting that up helps you develop and then integrate an effective program in a new setting because you've had those things lined up. And again, it takes work, meeting with individuals, building that trust and relationship. You're serious about this, and here's an outcome that we're all working towards. So that's how we started in Poland.
Awesome, thank you.
Think of one more question, then you play your hand up.
Oh, I get the last one.
Go for it. We'll have time afterwards if you guys want to.
So I actually kind of have like a multi-level question. One kind of from the economist, for economy and how this works, and everyone else kind of on a personal basis. But it seems to me, in kind of like a few short years, that we all we love the numbers. In academic medicine, you love to see the numbers and products, and nobody wants to give money to something you don't actually know is producing something at the end. So it's easy to be like, oh, there's this many sick people, we treated them. So kind of how do you walk that line of, oh, like there's sick people in the Dominican Republic, we did 1,000 hernia repairs, or there's sick people, in Haiti, and we did all this for cholera. Like, how do you kind of walk that line of building infrastructure and kind of focusing on that versus seeing people in front of you and helping them? If that makes sense.
I think, being one of the founding members of a very small nonprofit organization, that is a very difficult line that we deal with all the time. I mean, we have, our funding comes from people like you, private donors, family, friends, colleagues that we beg, and we want to use that money for programming and for training our providers to treat patients. But we need to measure our outcomes and be accountable. We've been focused on the beginning on doing research to measure our patient outcomes, just keeping database and doing follow-up on all the patients treated by our providers so that, now we've got a repository of tens of thousands of patients and we're, looking to see what are their outcomes so that we can make sure that we are having the impact that we think that we're having. but we have to, balance that, like, where do you put your resources, like into the, we could put more resources into more research assistants, and that might take away the resources from doing the actual work. And I don't have a great answer. It's a challenge, but both sides are important.
Pure economist answer here. So cost-benefit analysis, depending on what your primary objective is, if it's to save lives or do the most hernia repairs, you can develop courses of action that support that using the resources that you have. So it's an optimization model. It could be largely done off of mathematics. I want to preface that. I live with a medical anthropologist who constantly reminds me that it's more than about the numbers. So psychosocially, from a strict anthropological perspective, those things matter. And I think that's where the disciplines have to talk. I wrote down a comment as Dr. Chamberlain was talking. There's a great book called Uncharitable that really looks at how we, as organizations that rely on donated resources and grant funders, talk about how we build readiness, how we go about building an infrastructure to save lives, so that the expectation is it's not just about the number count at the end of the day, it's about the processes and the systemization of processes that set up structures that are sustainable. And in the nonprofit world, it's all about overhead. And we talk about overhead as a bad thing. Overhead saves lives. Overhead builds everything left of boom, left of emergency, of criticalness, to provide for a system that allows us to answer the call, to make sure that we're not waiting 45 minutes for an ambulance. But nobody, overemphasizing anybody, there are few donors that believe in overhead as a way to build sustainable programs and systems. I referenced in my prior session, you get Sarah McLachlan on the TV, holding a couple of puppies, and everybody wants to write a check because it speaks to the immediacy of the life-saving things that they do for animals. If I talk about why it's important to have 20% overhead or 30% overhead, because that builds sustainable systems, you lose donors, you lose grant funders. And I think we've got to change the dialogue. Dan Plotty has a wonderful 15-minute TED Talk, wrote this book Uncharitable that advocates for how we as nonprofits, as academic institutions, really speak to how overhead helps us achieve our ultimate mission of relieving human suffering, or whatever the respective mission of our organizations are.
This is one of the few times where I've actually really liked hearing from things from an economist. This is great. A couple of things. If we don't get this right, the planet is in big trouble. So global health is really for those students who are here, this is the way we need to go. So we need to get this right. More people are moving into cities. The cities have got to get this right. Organizing health services, managing chronic diseases, and so forth. So it takes a lot of people to do that with multiple specialties and multiple interests, medical anthropologists to economists to then leaders. That's really what my stress point is. You see overwhelming need. What do? This morning's presenter, very interesting. He said, no, we're not going to be part of the relief team. That's not our strength. That was a huge decision to make. Because everybody said, I want to go, I want to go, I want to go. And they're not effective in that. So saying no is actually very, very positive. It doesn't sound very sexy or cool, but you got to say no because it's not your strength. So I think that's really, really important. And cities getting this right is more and more the issue because more and more people are moving to cities. A really cool book, The Ghost Map. It's the story of the cholera outbreak in London. But it's written with this fast forward to cities. Cities' infrastructure doesn't get sewers right, they're going to be constantly plagued with cholera. Get it right, they benefit. Look what's happening in Flint. So getting that right is really important. It has other implications for how we develop global health here in Omaha and how we develop global health in other parts of the world. And it's really challenging because you want to do as much as you can for these needy situations. You just can't get to them because that's what the limits are. But it's really, really important to get this right because if we don't get this right, the planet's going to suffer because climate change and all these other big issues are part of global health. And so the students here, you're the future about this specialty, drawing on medical anthropologists, economists, and all the other specialties that brought me here to this. Great question.
Thank you guys so much. Just for the sake of time, we're going to end the questions now. This, I feel like, is just starting conversations. We've covered so many topics here. Just want to thank the panelists. Really appreciate you guys' perspectives, opinions, being honest about your own experiences. Thank you guys for being here, and hope the rest of the day goes well. I think now we're breaking for lunch, and there's a few things after lunch as well.
And just one quick announcement. I know that we got a little bit behind on scheduling this morning, but we're going to start at 1:40 back on schedule this afternoon. And there's a community fair happening down on the second floor where registration is, along at the same time as lunch. So you can either check that out before, after, or during, but there's some really cool organizations here next time.